Okay, hello everyone. Welcome to our live class. I'm just admitting a few more people here, so we're going to start in just about 30 seconds. We want everybody to be on the live class today. All right, so it looks like we have a majority of people coming on. So thank you again for joining us today. We're very excited to have you and look forward to an informative presentation and robust discussion today. My name is Dr. Krafasi and I'll be your webinar host. I'm joined on the line by Dr. Burdette, founder of Point Diagnostics, who will be conducting most of the presentation today. I'll pass it off to her momentarily to kick off the presentation on today's topic, the science of food. But before we get started, I'd like to go over a few housekeeping items. I've muted everybody by default. And secondly, if you have any questions during the course of the presentation, please submit them in the chat panel. The questions all come to me as a host, and I will be conducting live Q&A with our presenter at the end of the presentation. With that said, I'd like to pass it off to Dr. Burdette to start the presentation.
Thank you so much. Thank you for having me. I'm so happy to be here with Rupa Health. And those of you who maybe know a little bit about me, you know, in terms of partnerships and relationships that I develop out there, it is because of my background as a clinician. And so when I see something that works for me clinically, one of the first things I want to do is, jump up and down and share it with someone. So thank you guys for being here with us on Friday so I can walk you through something that's near and dear to my heart. I was just considering how long I have been doing this, and I have now been in the lab industry for 20 years. And when you think about particularly the functional medicine laboratory, when you think about testing out there that we like to complain about the most, it is food allergy or sensitivity testing. But then when we think about testing that we like to order the most, it is food sensitivity testing. And so we have this love-hate relationship with food-based testing. And why is that? Well, part of it is because the human body is always in flux. So the level of an immunoglobulin can vary a little bit from day to day. Sometimes we'll have more exposure. Sometimes we'll have less exposure. Sometimes we'll do something immunosuppressive. Sometimes we'll get stung by a bee and be more hyper reactive to things because of the histamine that's in our body. But with all of those bits of details, one of the things that I can remember thinking 20 plus years ago when I left naturopathic medical school, I thought to myself, who are the most successful practitioners out there I know? And one of them that came to my mind was a Dr. Alan Gaby. You may have heard of him. He wrote the natural medicine textbook. It's always right here next to me. It's here at my left right now. So very evidence-based, research-oriented, etc. Another I can think of is Dr. Klinghardt, and you guys might know him as well. I got the pleasure of being in one of his classes, and so eclectic and very naturopathic in origin. So when you think about the spectrum of approaches to clinical practice, in many ways quite different. What did they have in common? One of the major things they had in common is that they were very forthright in terms of dietary changes. Then when I joined Progressive Medical almost 20 years ago, not quite, it is a large clinic in the Southeast, one of the largest integrative clinics. I have a residency there. My partner, Dr. Gazzagoli, built this clinic over 30 years ago and has sustained it in times where natural medicine was not as popular. And what were part of the pillars or the foundation as I started practice there? Dr. Agoli told me two things. We want to make sure to work to detox every patient, and we have to change their diet. And so through working at Progressive Medical, really working with majority of the major food-based testing that was out there, and then running to Dr. Agoli and saying, hey, you know what? We're doing some amazing things here. Why don't we develop our own testing? I like these. They do quite well. People get better when they utilize them, but I think that we can take it to the next level. And so that was the birth of Point Diagnostics, one of the over 100 labs that you can get on Rupa Health. And I'm so happy to be in this partnership because it allows us to reach more people. So if you're confused about food-based science, You are certainly not alone. And the reason you're confused is because the field itself is confused and practitioners within it are confused. And so one of the things that we'll always grapple with is we'll listen to maybe even immunologists that will say, well, IgG testing doesn't matter. But then we'll use IgG testing with our patients and they'll get better. So it really seems to matter, and we're left, and then maybe we're talking to an insurance company about why they should cover it, and they might say something like, there's no data about that. And so the message out there is confusing. Now add to that, sometimes we see people run certain antibodies, IgG total or IgG4, and they say that they mean the same thing. Why all the confusion around this? Well, part of that comes from the history and how we've developed and how the research unfolds. And when we walk through the timeline of that, I think that some of the myths that we've heard are no longer as confusing. If you enjoy what you hear today, Rupa Health is sponsoring a 12-part series over at a different platform over at Personalogic's Health Academy. And this is my educational arm. And we're going to walk through many labs that they use and kind of put them all together. So if you're interested in that, just ask later and I'll make sure that you get the sign-up information for that. Is it an issue? Of course it's an issue. So what we see is the incidence of allergies are increasing worldwide for more than 50 years. Allergens among school children are approaching 40 to 50%. We see them go up astronomically, and this is just the IgE type, because still to this day, that's where we get most of our data, not all. And then just from JAMA, trying to figure out how significant is this? Well, even when we're only talking IgE, 11% say they have food allergies, and then that was verified by IgE, but almost 20% of adults believe that they were food allergic. Now, to you and I, the practitioner, that might seem low, but then think about how many patients have come in and said, I'm not sensitive to anything. You get them off foods, maybe based on some testing, and that's when we see our improvement. So what we know is that, and then almost 40% of those have reported at least one food allergy-related emergency dependent in their lifetime. Okay, so how do we reconcile this number? Well, that's not hard for anybody on this call. I always think of it like cholesterol. And if we'd been having a conversation about the best way to evaluate risk for heart disease 20 or 30 years ago, we might have all said cholesterol in terms of blood work. If you were to be asked that same question today, nobody would just say cholesterol. They would at least say HDL, LDL, triglycerides. Probably lots of us would say fractionated lipids. And so the point of that is that what we know is that there is more than one thing going on in the body. And so what we see from the literature is that while some of it is IgE related, at least another 50% is mediated by something else in the body. So it immediately draws our attention to the idea that maybe we should be measuring more than one reaction. And so on one hand, you'll hear docs say there's no evidence of IgG sensitivities. And so just real quickly, what's an allergy? That's IgE. It's an immediate reaction, anaphylaxis, shortness of breath. It may advance to the hospital immediately, maybe. What's IgG? It's not shortness of breath. It's not anaphylaxis. It's inflammation, washing over the genetics, causing almost any symptom, any condition to get worse. This is one of the hesitations in more of a standard of care approach. The idea is that a test should be associated with a particular symptom. Well, in the case of IgG, a test is associated with a process. And so, and that's part of the pushback. Well, if IgG were a thing, you would get an isolated group of symptoms. You would get anaphylaxis, you would get a rash, you would get joint pain. Well, you can make many things worse, as inflammation makes many things worse. And we have other markers that we've accepted that fall into this category: C-reactive protein, inflammation, could be cardiovascular disease, but actually a CRP, even right before it gets to 3, is more predictive for irritable bowel disease than calprotectin. So it's not the diagnosis itself, but the process. And the same is true of IgG. However, lucky for us, we're not in a reductionist, symptom-based medicine. We care about the process. And if we can figure out ways to lower the inflammatory load, that is accurate. There's hardly a condition that won't improve from that. So to us, that's a plus, not a minus. Of course, we're going to look for things that identify the diagnosis, but we're also going to look for the process. Is there inflammation? Are there nutritional deficiencies? Is there oxidative stress? Is there toxicity or mental emotional stress? All of these things can make many conditions worse. Why was food so important? Why did these practitioners that looked at things from a radically different lens both come to the idea that food was medicine? Well, because you eat, outside of intermittent fasting, many of our patients are going to be eating 2 to 6 times a day when you throw in snacks. And the gut is the size of a tennis court. So we either had the opportunity to create inflammation over something the size of the tennis court 2 to 6 times a day or not, to nourish the body, give the body the things it needs. And this is the heart of calming down that inflammatory load. Now, when we start to talk hard science, let me first go to a picture that you could well pull from an immunology textbook. And so if you were going to go to immunology lab class, or I'm not lab class, if you're just going to go to immunology, you would learn about types of hypersensitivity, and you would learn about IgE and how it activates mast cells. And then you would learn, but wait, that's not the only way we react to things. You could have an IgG reaction, and that can bind to some of the innate immune system, phagocytes, NK cells, or it could activate platelets as well. So we well recognize that when the immune system is responding to a bug, a virus, a bacteria, it may do so in multiple types of ways. Well, what is an allergy? It's immune confusion. And the immune system can also be confused in multiple types of ways. And so when we look at the ways that we could react to things, of course, IgE could be a reaction, but so could IgG, and so could IgG that binds to complement. And so the more of these we cover, the better. So, and much like my analogy to cardiology, we wouldn't all be still just measuring cholesterol. We'd be looking at the majority of ways we respond. You can take the best IgE allergy test out there that you can find that is run in triplicate or run 6 times to make sure, and all the controls look beautiful and all that piece of it, and that you will only see a positive titer 50% of the time. And that's even with an immediate reaction. So what is going on? It means 50% of the time there's some other way that the body is reacting to foods. Now, we like to say this is immediate and this is delayed. And so this will cause anaphylaxis, and this you gotta wait a while. It turns out that it's blurry. These lines between parts of the immune system aren't black and white. The immune system will do a number of things. For example, if I get enough IgG, it takes a whole lot of it, but enough of it can, in and of itself, activate a mast cell and cause degranulation. So this line that one will do one and one will do the other becomes quite blurred. So if we want to discover all the reasons our patients are reacting to foods, then we need to look at the multiple reactions involved. We don't have to go any further than the immunology textbook to see, of course, that there are multiple things happening. And so then we think, well, why? Like if you have ever had a conversation with an insurance company, for example, one of the things they want to tell you is there's no research in IgG. And we'll get to that. It's true. In 1965, there was very little research. And if you happen to turn to the part of the policy that's citing evidence that says there's no research, my bet is what you're going to find is something dated about 1985 or before. Well, about 1985, we weren't showing multiple types of hypersensitivity. We didn't understand the immune system in all its depths. But if we're allowed to fast forward to where the data actually is, we'll see that there's very good supportive evidence, of course, for IgG, but also for additional ways that we react to foods. So if we have the luxury to do so, and if changing diet is one of the most fundamental things that we can do for people, and everybody out there is going to agree that those that are able to make significant dietary changes do the best. Well, what about that you said in the beginning, that people's antibodies can fluctuate and it could be a little different day to day? That's true, but the trend will be there. And the things that spike the most and the things that trigger the most parts of the immune system are going to be the foods that you react the most to. And what are we supposed to do with this information? Well, we take the food away. We work on a gut-based approach. And then most likely at some point, you're going to reintroduce foods one at a time, with a couple of exceptions. We may never bring back gluten or wheat. That molecule is just so inflammatory. And we'll look at some of the reasons it's inflammatory even beyond an allergy, even after you heal the gut. You may never bring back dairy in some people. Some of their reactions that were absolutely horrid for them, those you might not bring back. But the little ones, those are things that you're going to reintroduce at some point and see if they can tolerate it or not. So when we're asking the question, has any harm been done? My firm answer is no. And so I describe IgE as immediate and possible, the hospital and shortness of breath. And IgG is this slow burning fire of inflammation. Does that mean it's insignificant? No. And I'm always think back to this kiddo who had a IgG reaction to gluten. Her mom's a pediatrician at Emory, and she had costochondritis, but it was so bad that she was already using a cane. And they said, when you get some pain meds with that, and your next option for treatment is more pain meds and a wheelchair. And this mom from a very conventional background said, there must be more for my daughter. And so what we saw was she was extremely IgG sensitive, reactive to gluten. And when she pulled it out, what we saw over time, with some mess ups, spend the night party, some pizza, back in pain again. We're all human, especially at that age. But what we saw over time is, I always like to say, she walks like this, which means texting and not with a cane. So like a normal teenager. So a slow burning fire, but still significant in how it can present in some of us. So if we've learned that antibodies have different meanings, then it makes sense to look at them individually. So one of the things that we do is we tease out various antibodies and other inflammatory mediators, and we measure what the response to food is. And so we look at, are you allergic? We look at, are you sensitive? And then we look at some things that act as barometers from there. So one of the things that you might think about if you are questioning is you might go, wait, look how this is broken down. The IgG4 is kind of here with the allergy piece. That's curious to me because I know some people that just measure IgG4 as a food sensitivity. So what does the data say? Well, what the data says is that IgG4 has the potential to block IgE. So here we sit, that mast cell waiting for IgE to bind to the receptor, and here in that mast cell causing it to degranulate and to spew histamine everywhere. However, have you ever had a patient who said, I did have allergies to dairy, but I grew out of them? I did have allergy to crab, most common adult onset allergy, but I grew out of it. And is that possible? Of course it's possible. If our relationship with food was such that the strawberry would often kill us, the peanut would often kill us, we would not be this successful as a species. And I would argue we're pretty successful as a species. And so what our body does, if at one time we make IgE, we then try to make IgG4. And the reason for that is if I can change how the antibodies I'm making, and now I can make an IgG4, it sits in this receptor and blocks IgE without stimulating release of the mast cell. And how do we know this to be true? There's actually so much data on this. And where do we get that data from? Right from, again, standard immunology. And so in standard immunological care, particularly allergies, one of the things that will be done if you have an allergic reaction is to suggest injections or sublingual immunotherapy. Why? Well, because those small amounts of food increase IgG4, blocking IgE. It's the mechanism of action by which injections of small amounts of antigen work. So it is very well documented. Part of the issue there is little tiny amounts will increase interleukin 10, and interleukin 10 is also the one that's in breast milk that says, oh, we should be accepting and we should not react to things. You're a brand new newborn and we don't want you reacting to every single food on earth. Other things that increase IL-10, probiotics, also your omega-3s. So when we think about decreasing sensitivities, you probably would have thought about both of those things, but it works for IgE as well. Now that's another question that we've had. Wait a minute. I was taught once an IgG, always an IgE. Turns out that is not a reality. In fact, the half-life of an IgE antibody is 4 days. Half-life of an IgG antibody is 21 days. Why? Because if you get stung by the bee and make an IgE reaction, we don't want that sitting around very long, because if you get stung within 4 days, that reaction is going to be so bad now that it's going to be more anaphylactic. So we try to break these things down rather quickly so that we don't have the impact from the immune system overreacting. We get told once an IgE, always an IgE, because it can occur. You can have the little kid who goes into anaphylactic shock from the peanut, 20 years later, gets a cookie that had peanut in it, still has that same reaction. But for most of us, a normal antibody response turns over in 4 days. And we see standard of care evolve with that as well. One thing they used to say was, if anaphylactic reactions in terms of IgE, never reintroduce. Now that's not the standard of care. You can reintroduce. It's suggested to do under your care with an EpiPen, but it is not an absolute no. So it's because we learn more about immunology and antibodies and Th1 and Th2 and Th17 response that our knowledge of allergies and food sensitivities has developed with that. Now, that original question I asked, why do some people then use this as a marker of sensitivity? Because before we figured out that it blocked IgE, we saw that it kind of correlated with IgE. So we thought, oh, this must be the sensitivity marker that really matters. But no, the reason it kind of correlates is because your body tries to protect you. And so what we do is we look at, are you making an IgE response? But have you also evolved to make this antibody that blocks the immunoglobulin? You can see how helpful this is. You put somebody on injections or slit, you remeasure their IgG4. Has it gone up? Great news. That means that they're now going to be more reactive or less reactive to the IgG reaction. Also, teasing it out becomes quite important, because IgG4 is the black sheep of the family. It doesn't act like the rest of your IgG. When we think about IgG immunoglobulins, you have IgG type 1 through 4, and types 1 through 3 are bigger, and they bind to complement, and they're more inflammatory, and they'll trigger platelets to react and release, and so they move around in a similar fashion. IgG4 doesn't bind a complement. It's a tiny little guy. That's what allows it to slot into this receptor over here and block IgE. And so if we tease it out and measure it separately, then we get a much better clinical picture. So one of the things you'll hear out there is people say IgG is not good because different antibodies do different things. True enough, but if you tease out the one that's doing something different, then we've overcome that clinical limitation. Then we further go on to learn about type 3 hypersensitivity right there in the immunology book. And that's where IgG is reacting with complement. And we first learned about this from researchers that worked on polio and the polio vaccine. And what they found was that you give a vaccine, and it was not the person that got the highest IgG titer that was the most protected. And so he's trying to figure out, well, it should be the more of this antibody that goes up, the more protected you are. So what else is going on? So dug around and looked to see what was there. And what he found is that when you had an IgG antibody that was bound to complement, it worked it better. So in the case of polio, killing it more, but in the case of reactivity to foods, that's worse. This is a more inflammatory reaction. And so in fact, that coupling of IgG to complement amplifies that reaction 10 to 1,000-fold. And so these are those patients, when you've worked with IgG in the past, and you're like, I don't know, the high ones didn't cause for migraine, the moderate ones did. Shouldn't the higher reactions be the worst one? Well, the reason for that can be because that higher level, that moderate reaction actually had complement present too. And so if we begin to look at, okay, yeah, this is a lower reaction, but you also have complement, then we're going to know that those are going to be the more important reactions. So we can have IgE, it can be blunted by IgG4, so it's nice to look at those contextually together. We can have IgG reactions that are amplified by complement, so it's nice to look at those contextually together. And so this is why we innovated to create a test that looks at multiple ways the immune system reacts, because it mirrors immunology. Again, the best immunologists will tell you IgE only has a positive titer 50% of the time, so we know something else is going on. Okay, that's a lot of data. And now you're thinking, that's well and good, Dr. Burdette, but how am I ever going to get through that with a patient? So we do some things to help with that as well. First of all, we give you a couple diet choices. There's one in there that takes out the highs and the moderates. That's your more restrictive. We do one that just takes out the highs. That's your less restrictive. So you can kind of pick and choose where the patient is at. They've never changed diet before in their life. They're crying they're using every last tissue on your desk. You might start with the less restrictive. They have a rapidly advancing multiple sclerosis, and then you want to calm down inflammation as quickly as possible. You're using the more restrictive. And so just giving you some clinical tools. Then all those immune reactions together, how do I explain to the patient this one's high, this one's low, warm, hot, cold, something like a Goldilocks kind of thing, just right. So we also did what we call an immune index. And it's a combination of adding some of those markers together, taking out part of the score for IgG4, and then looking at all those immune reactions and saying, which food do you react the most to? And which food do you react the least to? So we just ranked all 88 foods from top to bottom. So let's say your patient messed up and they took prednisone and they didn't tell you about it. The test is not worthless. Even though the immune system was suppressed, you're still going to know which foods are they reacting to the most. Let's say they are mast cell complex issues, and so they're just hyper inflamed and everything comes back positive, and you feel like they still need to eat something from day to day. You may say, you know what, you're reacted to lots of things, but I just want you to focus on the top 20. And so it's a way to give you a sliding scale so that we can really meet each person where they're at. Now, from a clinical perspective, what is the most clinically correct answer? To remove a food that's creating inflammation? Absolutely. It's just that what's most clinically appropriate is not always attainable by a patient. So if you're sitting there going, why is she giving the patient a way out? Is because sometimes we need ways to reach people, and so we'll have to moderate from there. Another thing we wanted to provide for you is, okay, you know, they might have reactions, and are those reactions showing up in categories? Okay, so they're having high levels of reactions. When I look at this column, their high levels of reactions are over here in the FODMAP area. So maybe the foods that are FODMAP, you know, onions, garlic kind of thing, are creating more inflammation. And maybe if I look at that style of diet, my patient could further respond to that. So I generally will say, just take out what they're most reactive to first, see how they do. And then if you're like, that's part of the picture, but something else is going on, then I would use these secondary tools to say, okay, you're showing up with tons of oxalate issues. And we'll talk about on the series that I'm doing on Personalogics, you know, some of the other testing that's out there that can look at this and how you might fold that in after you figure out some of their core issues. Or you're reacting a lot to histamine, foods that are high in histamine. So let's do a low histamine diet with you. And maybe you'll think, and maybe I should measure their diamine oxidase, the enzyme that degrades histamine. I'll go back to Rupa and see if anyone does that, and I'll figure that part out from there. So, you know, recognizing there's a complexity here, but also recognizing that it's part of precision medicine is really creating the least inflammatory diet for every patient. You know, one of the things patients might say to you, they say to me, well, I sent my friend here last week and you ran the same test on her. Do you just run this on everybody? And the answer is no, because there's always some extenuating circumstances. But in general, do I want every patient to have the least inflammatory diet possible? I am proud to say yes to that. And I do not feel like in any way that's cookie cutter medicine, because we have to figure out the process for each individual. A couple more tools, then we give you these graphs, and the place where they pull out are the families that you're most reactive to. So that could be a second thing you do. You go, okay, you're still having some level of reaction, so we're going to pull out the grain family. Never let a patient try to trick you into pulling out the vegetable family. I don't think we'll ever do that. I think those are going to be necessary. But some of the other things like fungus and so yeast, and then we have nice tools to help with this. Ask for our physician guide. It will give you a yeast-free diet. It will help you with what other grains you want to pull out. A lot of common question. Food families, a nice list for that for you to look up quite easily. So we would never have this conversation without having a graph that looks like this. Someone's got to throw it up and show the picture of leaky gut. But, you know, just the more we learn, the more science comes into this picture. So over here, actually, they're showing the first part, they're showing how to make a healthy gut. And I think that's fair enough that we talk about. So here's your fiber. It gets chewed up into short chain fatty acids. Next week, I'll be talking about what some of the various ones, acetate, butyrate, mean when we're looking at them on stool testing. But look at this short chain fatty acid. It comes down here, turns off inflammasomes. Well, those are the things that are ripping apart the lung in COVID. Turns off one of the most inflammatory mediators, sends a signal back to build a healthy gut, to have that integrity. So it's your microbiome and it's fiber and all of these things. And I just bring that up to say, absolutely, food removal is a good idea, but if you want to retrain the immune system, layering some probiotics with that, some immunoglobulins and things that create fiber are going to help your patient get better faster. And then when that signal happens, and when we have a diversity of microbial diversity, then you see also it improves these guys, the Treg cells. So that signal right from the gut. And that Treg cell is the one that puts the immune system back in balance. That Treg cell is the one that's underactive in autoimmune conditions, underactive in COVID, where the immune system goes haywire. And so all of this immune priming happens at the gut. So then over here where you see the gut lining breaking down, now what's happening is you're moving towards this Th2 response, more of an inflammatory response. You activate that naive T cell and we're off to the inflammatory races. So you bet your bippy, I want each patient on the least inflammatory diet possible. And so, yes, food allergy too is a growing problem. It's not just environmental foods as well. What we see is that they're going up, but even though they are going up, interesting, we're changing what we're doing around peanuts, introducing it a little bit earlier. Now, why would that be the case? And it turns out one of the reasons is because the immune system is still more flexible at that moment in time. And if you're still breastfeeding, then you're giving that IL-10. And remember, desensitization increases IL-10, but Mother Nature did it first. She provided it through breast milk. And so the idea is if you're getting it at the same time that signaling is going on, you're going to have a better response to it. Another time you got a better response was here, kiddos reactive to peanuts either got peanut immunotherapy injections or they got peanut plus lactobacillus. And a pretty amazing thing began to happen. What you saw was at the end of the trial, the children that got the lactobacillus as well, 82% became tolerant to peanuts. If you're looking at the placebo group with no work on the microbiome, 4% acquired tolerance. Think about that. So if you've taken a patient off their foods and they're still not getting better, ask them, are you actually really taking that probiotic I put you on? Because that is key. And then of those 80%, when they got the probiotic with it, 4 years out, 70% still had long-lasting effects. And in the group that did not get it, I think I don't even know how much of that 4% had any long-lasting effects, if any at all. And so I say this to say, if you remove foods and you're still not getting there, definitely we want to focus on what we can do for the microbiome. And then the next question is always going to be from the patient, how long do I have to do this? I used to like the hem and haw and say maybe only a few weeks, maybe a few months. I think that's a disservice. I think you'll be able to start bringing some things back in, but those larger immune reactions, you probably really want to keep those foods out for at least a good 9 months. And the reason for that is think about desensitization. They're not going to put you on that for 3 months. That's 1 year, 2 years, 3 years. And if we're really retraining the immune system, you need to keep those guys out for a longer period of time. And you need to stay, you can titrate it down, but you need to stay on some level of probiotic and you add your glutamines in for sure. And then for me, I'm a huge fan of bioactive immunoglobulins, just giving what would be in breast milk, because it sends those signals to say, when we receive food, we're going to see it as normal. And I remember almost getting run over at a conference. A gastroenterologist just, Cheryl, yes. And he was so excited to tell me, he said, I've been in practice 20 years. I'm having the most success I've ever had using your protocol. And I remember at the time thinking, protocol? I don't have protocols. I never do the same thing. Yes, I do. I want each patient to have the least inflammatory diet possible. So yes, I do have some go-tos. And what he was talking about was food-based testing in this vein, and then using probiotics, using some functional foods, and using immunoglobulins. So when people say there's no research on IgG, they're probably thinking about the data, right back here in the 80s somewhere. Well, look what has happened. So again, when someone says that to you, ask them for what research they're citing, and it's probably going to be not from this decade. And so, like I said, I've been in the lab industry for 20 years, and when I would first be asked to write a paper about IgG and food sensitivities, I was, doing what these people are doing, looking at, this handful of studies back here. And then, every couple of years, go back through the research, see what I've missed, keep doing that over and over. And my last time doing that here during COVID, why not go back through PubMed and see everything I can on IgG? Man, has the data really solidified? So if you think you're practicing voodoo, hoodoo medicine, you are not. You are quite evidence-based in your approach. And so, I said that it can help make most symptoms better. That's true. But there are some areas where the research gets more dense. Of course, irritable bowel disease, IBS, migraines, depression is an area that very much shines with food-based reactions. And so So yes, there are times when anything is more or less indicated, but you are always going to eat food. So making better choices is generally going to be good for us. So here, they actually got around to looking at, hey, when people had symptoms and there was no IgE, we tested IgG. And guess what? With urticaria, right? You would have said that was so IgE. IgG was present, and so they conclude that we should be measuring this if IgE is not present, or we could just do it all at one time so that we have the most complete picture for the patient. For migraines, lots of data with IgG. Also, when you do the Venn diagram, if you've got a migraine with IBS, you are most certainly looking at an IgG reaction. In fairness to migraines, they are influenced by a lot of things from foods, not just IgG, but of course like tyramine containing foods, lots of sugar processed food that can trigger migraines in some people, and more processed foods. We see studies about that. So it turns out basically brain gets angry when we're eating things that are not so great for us. So big connection there. And again, what it helps us to establish that yes, what happens in the gut does not stay in the gut. It creates these systemic symptoms as well. And so what we see is that IgG reactions are identified and involved in even ankylosing spondylitis, right? Fusion in the back, yeah, because where did that inflammation come from? Originally the gut. So of course your abdominal pain, diarrhea, distension, stool shape, distress, non-celiac wheat sensitivity, IBS, IBD, autism. These are some of the hot spots that you see for food sensitivity research. And here I put some references in here for you, easy cut and paste in terms of making some handouts and whatnot. Rheumatoid arthritis, if you go in and you look at the synovial fluid, you will find higher levels of IgG antibodies to food. Now, interestingly, some other things that you can find in there are antibodies to LPS. So always one you want to think about in anything autoimmune, that immune reaction to LPS. LPS will grab onto your Treg cell and it will decrease its activity. So a big player in autoimmunity, as food sensitivities are, you biopsy that synovial fluid, you are likely to find higher levels of Epstein-Barr virus too. Interesting, right? So sometimes we're like, how much does the Epstein-Barr virus matter? One way to answer that is, have we seen it associated with the condition in any clinical data? And so these are things that we want to think about. We think about foods someone's eating. We want to think about autoimmune triggers like LPS that's in the gut. And we want to think about various infections that might cause us to make those antibodies as well. What this research is basically saying is a functional medicine approach is what we should be doing. And so this is, fascinating too. So here they looked at people that had IgG reactions to foods and they were experiencing things like diarrhea and constipation. And what they saw was they had higher intraepithelial lymphocytes and the digestive tract, very similar to what's seen in celiac and colitis. So it's not the same. It's not the same transaminase, but the inflammation is still resulting in the same type of immune presentation. So this is why it can create some of the same symptoms. And check this out too. More with the IgG1 and 3, with a decrease in the IgG4, the one that blocks allergies. So we see that pattern showing up in terms of people with celiac disease. And so when people say, well, IgG has nothing to do with celiac disease, well, it might not be the go-to for how we diagnose it, but it can certainly be a process that makes it worse. It just makes sense. You can have celiac and still have sensitivity to wheat, and it wouldn't be a great idea to keep eating wheat in either case. So thank you, Dr. Driscoll, who always does great work in terms of published IgG associated with irritable bowel disease. And wait a minute, IgG4 was associated with pain frequency and quality of life. I thought I said it blocked IgE reactions. How would that be true? Because nothing in the immune system likes to do just one thing. The body doesn't make it easy for us like that. So it does turn out there are certain conditions where IgG4 gets confused and quits working more as a blocker. And so one of the things we do on our diets is we put, instead of just always taking out high IgG4 reactions, we put them in their own column, and you can go, okay, you have a condition like rheumatoid arthritis that's more affected by this, so I want you to take out the IgG4, or yours isn't so affected by this, so you can leave it in. A big one that probably a lot of us deal with, autoimmune thyroiditis. So for your thyroid things, they looked at thyroglobulin antibodies, TPO antibodies, and compared the amount of damage they were doing compared to IgG4 and to complement. And guess what? IgG4 and complement did more damage than thyroid antibodies. So if you want to remove the foods that are causing immune confusion, attacking the thyroid, these are the parts of the immune system that are confused. People say, which is the best food test? Well, what part of the immune system is confused in your patient? And that would be the way to line those things up. So yes, Crohn's patients got better, C-reactive protein went down, and another study with Crohn's patients, when you took out IgG reactions, interferon gamma went down, abdominal pain decreased. So all these things just corroborate the idea that yes, there is data around IgG. So let's speak a minute to methodology. Why can different tests be different? Well, if somebody brings in something from, just one of your standard big labs out there, they're of course looking for ways to cut costs. So they're going to use a polyclonal mini antibody system in terms of looking at these things. We use a monoclonal antibody system. So this decreases cross-reactivity. So if you can't always compare every test because it matters what type of testing that you're using. And so we're taking precautions using this monoclonal to really try to decrease that cross-reactivity as much as possible. You can't, it's not absolute because you'll still have some amino acid sequences that are similar from one thing to another. And so it can tell us different pieces of the puzzle. Some things are just different methodologies, like a live cell methodology. It puts food next to the cell and then sees if it's going to grow. Well, and that can tell us some things, but there's only inflammatory cytokines 36 to 42% of the time with that methodology. Sometimes your white blood cells growing is because it's preparing for phagocytosis. So for example, antioxidants can do that as well. So there can be some confusion in what you're looking at there. Are you using when you're coating plates, are you using organic versus non-organic? And when you coat those plates, if you coat them really heavily, then you can get an antibody to bind. If you coat real lightly, then nothing binds. So all these methodological pieces go into really making a good test. If you were going to work with a supplement company, you'd probably want to know that they batch monitor, that they look at ingredients that are coming in. One that I work with probably sends back more than they accept. So you want to know the same thing in terms of food sensitivity. So some of the things that we do is we run knowns at the beginning, middle, and end of our run, and then make sure all that looks the same at the end. We put controls on every plate as well to make sure they're behaving correctly. We correlate from batch to batch. So we're doing a lot to make sure there's standardization. Why do we have more food reactions? Yeah, not news to anyone here, but something like glyphosate all over your food. If you douse your food with a chemical, it irritates the immune system and you start to see more reactions to that. So some people will say, well, why look at all the other IgG? And they'll say, well, you can only get reactions to proteins. But that's not true. We're looking at IgG2 as well, so you get that polysaccharide thing. IgG3 does both. And so this is why it's important to tease out what you're looking at and where. What about retesting? When should I look at my patient again? Well, really, you're going to see a significant decrease in about 6 weeks. But I would encourage you to at least wait 3 months, sometimes even a little bit longer. And the reason for that is you really want to heal that tissue. You want to give them a chance. But the reality is the half-life of your IgG antibodies, 21 days, IgE, 4 days. So, and that's why they'll come back at their next visit and say, I'm already feeling better. But just like desensitization, to really retrain the immune system, we kind of want to dig our heels in and go the distance. For me, the goal is not to take out every food forever and ever and ever. It's to limit those ones that are really triggers for you, take out foods long enough to retrain the immune system. So eventually you're eating more foods without pain rather than well, plenty of foods with pain, or even less foods with less pain. The idea is really to open up the diet here. Remind patients of that because they're only hearing what you're taking away from them. A nice little trick that I learned from that, one of the dietitians that I get the pleasure of working with, Lee Russell, she taught me, don't start with the negative, Cheryl. Don't show them what they can't have. Show them all the foods they can still have and say, do you like any of these? And certainly there'll be something on there that they like, and then say, okay, now these are the ones you can't have. So we'll focus on what you do like. Other things that can blunt an immunoglobulin response if you're just like, I know that they're reacting to food, we'll check in with them about what they're drinking. And if they're drinking as a male more than 2 drinks a day, as a female more than 1 drink a day, then it might not be the test, it might be they blunted their own immune system. Look inside their mouth. Is there periodontal disease? This is another reason that you'll be immunosuppressed. Gender, women, we make more immunoglobulins, men make a little less, and then you might diagnose an IgG subclass deficiency as well. Some of the things that we do to process food can make them more antigenic. It causes proteins to fold in weird ways, and you'll start to make more antibodies based on that. And I know that we all know this, but it's just nice to see it in the data. And it's not like this just came out. We've known for a little bit now that when you are on protein pump inhibitors, that you're going to decrease release of pancreatic enzymes, and that's going to leave intact foods. And this is going to cause more sensitization and allergic reaction. So these people that started having heartburn that now get on antacids and protein pump inhibitors and all this piece, of course, they're setting themselves up for food sensitivities long term. Another interesting thing about it is, just independent of all that, your PPIs, they cause, you can tell the scientists were bored, they cause expression of the morphogen sonic hedgehog, which is related to the development of atrophic gastritis. We knew it. This hypoacidity is not a good thing. Sugar, you could get them off all their food sensitivities and they're still eating a highly processed diet. What does sugar do to protein? What is a hemoglobin A1C? It is protein shriveled by sugar, and that's what we measure for the diagnosis of diabetes. So the same thing's happening in your gut. Your chocolate cake next to your steak, your ice cream there with your burger is shriveling those proteins, and they begin to look weird. Also, no big surprise to anybody here, that glycation also disrupts the microbiome as well. Some fun food facts. Some people say, why are you looking at candida reactions on your test? No one sits down and eats a plate of candida. No, they don't. But if you are making antibodies to candida, they can cross-react, and they can, and this is from the Lancet, pretty high impact factor journal, they can cross-react with the amino acids in gliadin. And so you want to treat the candida if you want to get rid of antibodies to wheat, vice versa. They say to you, I haven't had that in forever and I'm not cheating. These antibodies shouldn't still be high. Check out candida. Another piece of this puzzle is, another reason we want to put this on here is, if you have a lot of immune reaction to candida, you probably have candida. It's possible that you could have gotten rid of it recently and the immune system's still reacting, but more likely is the immune system's reacting and it's there. Well, if you leave candida hanging out in the gut, one of the things it likes to do is it likes to chew up secretory IgA. And that's 80% of your gut lining. But the other thing secretory IgA is your first line defense. So you chew up secretory IgA, and now you don't have that first line defense. What happens when things float into the body is the rest of the immune system, the back line, says, oh my gosh, I better make up for my buddy who's not doing anything on the front line. I better amplify. So IgG goes up even more. IgE goes up even more. And so these are those patients, you've taken out the foods and you've worked on diet and their titers don't go down. they may have low secretory IgA. It might not be time to run the next food test yet. Now you might be wanting to run a stool test. Look at that secretory IgA. As that improves, those backline titers will continue to calm down. And just some other fun ones, just this cross reactivity isn't just within food families. Our physician guide has all these kind of lists in there. I've never had a calamity in my life. Why does this test say I'm reactive? There's a cross reactivity with cockroach. I've been vegan since 1961. Why am I showing a reaction to beef? There's a cross reactivity with tick bites. So understanding some of these reactions with foods can also help us understand some of our next points. And we also look at a reaction to mold. So you might say, I think that these are more mold reactions. We need to think about getting you off moldy foods, but also seeing how reactive you are to mold. And so we can use this as a branching point to start thinking about many other things that might be going on. How bad is gluten? Well, I think we've really mucked it up, and that's why you see, even serious beer makers making gluten-free beer and gluten-free foods, and they certainly don't taste like cardboard like they did 20 years ago. I can whip up a gluten-free scone and you wouldn't even know the difference. So we've come a long way with this, and that's really good news. But again, it's also back to that microbiome. Check out this study. They looked at patients with celiac disease and they gave them baked goods made of wheat. Being a clinician is very different than being a scientist. Scientists trying to provoke it and see if you can suppress it. We would never do this, right? It would scare the pants off me. But that's what they did. And then one group got this wheat that had probiotic in it and one did not. And if the probiotic was there, you did not see the same reactions to the gluten, and it was bifidobacter. So I just say this to say we can retrain the immune system. That is why we breastfeed in the first place, is to set up that diversity of the microbiome. That's why you're removing inflammatory foods, so they're not killing off your good, healthy flora. And so there is light at the end of the removal tunnel. Then, another thing people will say is, I've never eaten anything and I'm reacting to this. Well, sometimes you make an imperfect immunoglobulin. We are not perfect beings. And so you might have made an immunoglobulin that was one amino acid off and now it binds to the wrong thing. So sometimes it's not the test fault, it's the human being person's fault. Then you might have run all these looking at IgE, IgG, and they're like, Dr. Burdette, they're still sensitive to something that didn't show up here. Well, it turns out, even in our effort to be the most complete, there are other reasons we can react to food. They can release serotonin or tumor necrosis factor or even arachidonic acid metabolite. So we're getting there, but there are a myriad of reasons that we can be food reactive. But ultimately, the proof is in the dairy-free pudding, as I like to say. And so one of the things we did is we looked at what happened when people came off their food reactions based on this testing. And what we see is a variety of symptoms that were greatly reduced, not 100%, but a large reduction in symptoms, because as you remove that inflammatory load, what we are able to see that we are less reactive. And so, just in general, this is not the only way we calm down inflammation, but managing the intestinal barrier is, of course, a major way. And then we're going to do other things that we do in functional medicine. We're going to think about adrenals, and we'll be talking about that in the 12-part series. We're going to be thinking about these highly anti-inflammatory molecules that we make. Well, what do we make them from? DHA, EPA. So we'll be thinking about things like omega-3 fatty acid status. We're in lymphatics. Open up your physiology book. That's what it says. Lymphatic system is there to clean up inflammation, necrotic tissue. It is an anti-inflammatory system. What can we do to stimulate it? Well, exercise is a big one. We can put castor oil packs topically. We can use some drainage formulas, some botanicals that have an impact there, like cleavers and poke. And so we're going to utilize our functional medicine approach to create the most meaningful anti-inflammatory strategy possible. And I remember once when I was doing a talk to a group of residents in med school, and they said, they don't know anything about functional medicine, go out there and teach them all about it in 1 hour. And I was like, how do you even teach everything affects everything, and you got to work on all this stuff, and so what I remember thinking, because this is my clinical experience, that talking about the gut and talking about successful management of the gut, removing those foods, and if it's not a food, it's a bug. Those are your basic two choices. So if they've done a lot of work on foods, now we got to think about stool testing, but removing those foods, clearing out the bad bugs, getting on a good healthy diet, doing those things, I have seen a little bit of assistance from a functional food in there. I have seen that be as effective as prednisone. Is it as fast? In an extreme way. If we basically, I'll have people do yank out everything that you ever thought you were reactive to again, because the body changes. Go back to your more restrictive diet, and I'll do a functional food, and you do nothing but that three times a day, 3 days in a row, and that I found work as quickly as prednisone. It's not as easy, but it doesn't have the side effect profile. So when we're thinking about ways that we can control inflammation, certainly standard of care has tools, but they're not without their downside. And we can do the same thing by treating the person, working through that gut-based health. And whether or not it's the most eclectic practitioner out there you can think of, or someone who's highly evidence-based talking to you about this study, that study, one of the things you'll probably find they have in common, if their practice is successful, they spend a lot of time focusing and thinking about food. So I wanted to thank you guys at Rupa for letting me come on and speak about this. And I also want to thank you guys as clinicians for being out on the forefront, because you were the ones for years saying, I think we need to look at these other types of reactions. And I do think they're meaningful. And yet your patient will go off and say, well, my doctor says there's no research on that. Well, I want you to know that research has caught up to you. And we can see these patterns when we kind of look at how the tracing of the research, we can also tease out some of our confusion as well. But very happy to share this testing with you. And we'll talk more about other styles of testing in the future. Thank you so much.
All right, Dr. Burdette, thank you so much for that very informative webinar. That was amazing. We have a few questions that came through if you'd like to answer a few questions.
Love to.
All right, so the first one that we have is, what were the food sources of IL-10? They listed some probiotics and breast milk. Was there anything else there that you had?
Yeah, so it's probably not food sources that we're going to get IL-10 from, but you absolutely, probiotics increase IL-10. Food desensitization increases IL-10. Omega-3 fatty acids increase IL-10. Immunoglobulins increase IL-10. So, and so they mimic what breast milk is doing. Breast milk is also a way to increase IL-10. Oh yeah, immunoglobulins come from colostrum, a breast milk kind of thing. That's a way to kind of fold that into your head there.
Beautiful, beautiful. And the second question is, does the test check for raw and cooked foods?
No, we don't. And you're absolutely right to think about differences between those two. But what we did is we looked at over 300 foods, and we looked at different preparations, and we looked to see how much different there was. And so what we saw was there was a really steep drop off. There wasn't that much of a difference between raw and cooked, and some of those other 300 and something minus 88, you didn't really see come back very often. So what we decided is, in order for this to be utilizable, it also needs to be affordable. And so we said, let's pick the things that have the most immune reactions. And since we did not see a huge statistical difference between raw and cooked, we decided not to test both ways. Now, in terms of clinical practice, if you pull one out and they can't handle it raw, then absolutely cook it, or vice versa. Changing those proteins can go both directions. So certainly, yes, some people will do better if it's slightly blanched kind of thing. But statistically speaking, there was more overlap, more similarity than more discrepancies.
Great answer. Thank you. The next one is, can you go over the specific tests that you'd recommend for food sensitivity?
Yeah, so what we were looking at today was we were looking at this test from myself, the lab that Dr. Agoli and I started, and it is. Oops, I shared the screen. There we go. And then it's from Precision Point, but this is the beauty of Rupa, is that if you have a patient and you're like, oh, I really want them to have an organic acid, I want them to have precision points, food sensitivity, and I just want some basic lipids from a standard place. You just click, all those kits go out. It's super easy. And so I'm really, you can have the best test in the world, but if you can't get it in people's hands, it doesn't matter much. And what Rupa's really done an excellent job of doing is making it easy for these tests to get in the patient's hands. And turns out, no matter how great of clinicians we are, people don't really want to go in for blood draws and lab work. So any obstacle we can remove is important.
Perfect, perfect. We just have two more. The first one is, do you have a list of the protocols, some of the protocols you mentioned for positive food reactions?
Yeah, so what I will do is I will put those in the hands of Rupa by the end of the weekend. And so you can go ahead and email now, but give them till Monday end of the day to email you back, and they'll send those out to you. And then I can use exact product names and all that kind of piece too.
Amazing, thank you. And one last one here. You mentioned not eating a food for 9 months after a test is positive. Can you explain a little bit more about that?
Yeah, so I would liken that to if you are going to go a conventional route and do injection therapy to retrain the immune system. You're doing that for 1 to 2 years easy. And so the same is true if we're trying to retrain the immune system in a different way. And so the way we're retraining the immune system is to build that gut lining back, because that also increases that IL-10. That tells the immune system or that tells the body that this food is normal and we don't want to react to it. And desensitization does that as well. And so when we're thinking about that, what we know is if we're going to retrain the immune system, it just doesn't happen that quickly. Yeah, you're going to quit having symptoms a lot faster. Some people almost immediately when they take the food out. But the question is, can you bring it back in and not have a reaction? And if that's the ultimate goal, pulling it out for longer is probably what needs to be done. And I mean, I think I like to explain it to people like, we're building tissue. You don't get to go to the gym for 6 weeks and have beautiful biceps. It takes some training to get there. And so in a similar fashion, we got to kind of be vigilant for 9 months. And so I think that when patients understand, okay, this is the goal, but the goal is ultimately to get me to a place where I can eat more foods without pain, that they are not as blown away by that. However, if you want to start off by saying we're going to take these out for 4 to 6 weeks and then reevaluate and kind of ease them into that, then for some people that might be necessary too.
Perfect, perfect. All right, everyone, thank you so much for attending the presentation today. And big shout out to Precision Point Diagnostics and Dr. Burdette for this amazing presentation. You did an amazing job. Thank you so much, and hope to see everybody on the next live class.